No replacement letters, right? Okay. Good morning, everyone. Only 13 minutes behind, which is pretty good. The hour of 8 a.m. having come and gone, the House Human Services Committee shall come to order. We don't have any replacement letters, so we're going to start with the clerk taking roll. Take it away, clerk.
LaPointe,
Here.
Hammond, here. Brielle, here. Cassidy, here. De La Rosa, here. Grassi, here. Haas, here. Meyer, here. Moeller, here. Morris,
Claire just sent 46.
Ness, here. Schmidt,
Here.
All right, with 12 members present, we do indeed have a quorum. So with that said, we're a little behind already, and we ambitiously are going to hear 20 bills today. So hopefully we can be as organized as possible. We can be as tight and concise as possible with our comments and questions. I'm going to read through all the bills we're going to hear. It's going to take a moment, but there's no other way for people to know what is going to be heard. We are going to try to move through somewhat based on seniority, somewhat based on if we have people sitting in the room, which I can see right now we do, that have bills on the docket, that have witnesses that aren't on this committee. For instance, my one bill will go at the very end. So here we go. Here are the bills that we are going to hear today. HB 4580 from Leader Rita, HB 4584 from Rep. Lisa Davis. Note, this is not the order. I'm just reading the bills. HB 4602, Rep. Stewart. HB 4606, Favor Dias. HB 4700, Rep. Stava. HB 4728, Favor Dias. HB 4785, Rep. LaPointe. HB 4834, Rep. Cassidy. HB 4868, Rep. Elick. HB 5062, Leader Lilly. HB 5235, Rep. Harper. HB 5408, Rep. Moeller. HB 5466, Leader Lilly. HB 5574, Rep. Guerrero Cuellar. HB 5193, Rep. Kelly, presented by me. HB 5258, Leader Lilly. HB 3823, Leader Hernandez. HB 5239, Rep. Manley, presented by me. HB 5102, Rep. Ness, and HB 5458, Rep. Meyer. Again, that's not the order. We're going to try to be sensitive to people's time and seniority. If you're on the Human Services Committee, your bill will come later. We also know some of you have to step out to present other bills. So we're going to do our best. And if you have comments, text me. Okay. All right. We are going to start with Leader Hernandez, sitting in the front row. This is HB 3823. And to all the chief sponsors who are going to be presenting, if you could make clear at the very beginning if your bill is fully baked, at least in your eyes, or if you intend to bring an amendment back to committee and hold it on second, that would be great, because I think that will save some time.
Yes, good morning, Madam Chair and members of the committee. Could I continue?
Yes, you may.
Okay, so I am right up front. I'm going to let you know that I am seeking to continue working on the bill. I am working with DHS for us to come to some term with the bill. There are some concerns, so I'm looking to work with DHS, bring back an amendment to bring us to a satisfactory state. So I'm just going to give a brief explanation of what the bill does and then ask if we could move it There is well, I'm going to be looking for an amendment, so I'm just going to ask if we can hold it on second. Okay, House Bill 3823 creates the Pathways for Community Integration Network. This is basically is creating a formal statewide framework to serve limited English proficient households through trusted multilingual community providers. It will also define a clear, accountable, and standard model of care. Organizations must deliver a formally partner to deliver a full set of integrated services that address health, employment, legal stability, and community integration together, not in silos. And lastly, strengthens quality, consistency, and oversight. DHS is authorized to certify providers, set standards, and provide technical assistance, ensuring public dollars support effective, standardized, coordinated care. So basically, a program to connect, not expand. And with that, I ask if we can approve it and ask if we can just hold it on second, and I'll bring it back.
Thank you, Leader. We'll take a look at the witness slips here. Looks like we have 5 proponents, 2 opponents, and those proponents are the Illinois Collaboration on Youth. That's the main organization. Looks like there's somebody for self, and then for opponents, we have 2 names, Laura Egan for self, William Ike, that also looks like self. I know I have a question, but let's pause and see if members of the committee have any questions or comments. No, okay. 2 for me. Leader, who, you know, we just read the witness slips, but since you're here, who would you say is the lead advocate or lead proponent of this bill, just so we understand where it's coming from?
This is a area that I've been working over sort of my career in this space. It's always been about bringing accessibility to limited English proficiency speakers, and so it's that accessibility. This is programming that I have worked on. So I'm just trying to basically just put this in statute to assure that there is existing services for this population. So it's on working work that I've been doing. So I don't know, I guess I'll call it myself.
Gotcha. That sounds good. And then can you give us either you or perhaps the Department of Human Services, I don't want to take too much time, but like just a little flavor of I don't want to call it opposition, but a little flavor of the conversation about what you're going to look at in an amendment.
Good morning, members of the committee. Luis Andrade, Director of Legislative Affairs with the Department of Human Services. Happy to work with Leader Hernandez on this legislation. I think some of the concerns that we have are how we're going to operationalize this. We currently operate a very, very similar program, and while we support the intent, I think it's much more of how we're going to operationalize this. So we're happy to continue working with Leader Hernandez over this session to hopefully try to come to some kind of agreement, understanding that it's a very high priority for her, as she just mentioned.
Excellent. That's really helpful. Leader, should we adopt the amendment or move forward with the underlying bill and hold it on second?
No. Adopt the amendment number 1, and then my hope is to come with the second amendment to make it whole.
Okay, excellent. And Louis from DHS, if you could just file a witness slip since we did pull you in on the record, and thank you. Okay, so Rep. Moeller moves that House Human Services Committee do adopt House Committee Amendment 1 to HB 3823. All those in favor say aye, opposed say no. In the opinion of the chair, the ayes have it. The amendment is adopted. So we got that taken care of. And having said all that, I don't see any more comments or testimony. So Rep. Moeller moves that House Bill 3823 do pass as amended. Is there leave?
Partisan pending the amendment, please.
Excellent. Okay, partisan leave pending the amendment. So there being 8 votes in favor, 4 votes opposed, 0 voting present, House Bill 3823, as amended, is declared passed and will be favorably reported to the House floor. Thank you, Leader Hernandez.
No, thank you. All right, have a great day.
You too. Way to kick us off. Okay, I see Rep. Harper sitting in the front row. So we'd love to have you come up and move forward with House Bill 5235.
Thank you, Madam Chair. Thank you, Leader Hammond and members of the committee. I'm pleased to present House Bill 5235. And before I begin, I do want to say that we are working on an amendment with DHS that will bring them to neutral. So we're just hoping to hold it for that amendment. So this bill, House Bill 5235, creates a coordinated statewide approach to the charitable food system so that surplus food, donated food, and publicly supported food programs are aligned and more effective. Now, this bill does not create a new grant program, but it helps organizations better access existing funding by creating a more coordinated statewide system. I respectfully ask for an aye vote, and I do have a representative here from Dion's Dream to Chicago to further explain the bill and answer any questions from members. Thank you.
Thank you, Rep. Harper. In terms of witness slips, we have 12 proponents and 1 opponent. And just for a flavor of the proponents, of course, we have Dion Chicago Dream. We have something called Real Food Media, something called Glaciers End, the Illinois Food Justice Alliance, Prairie Oasis Farm, a few selves. And then for an opponent, we have the Illinois Department of Human Services. So with that, because we have a witness here, we will have your witness take it away, and then we'll see if there are any questions, comments.
Thank you so much. Good morning, Chair LaPointe and members of the committee. Thank you for the opportunity today to give a brief testimony on the bill. So I'm Catherine Serta. I am part of the Dream team at Dion Chicago Dream and our Director of Food Policy. And Dion Chicago Dream is a nutritional philanthropy that uses last mile logistics and delivery to address food insecurity around the Chicagoland area. In just 6 years, we've purchased, packed, and delivered over more than 6.5 million pounds of fresh produce all over Cook County, resulting in millions of dollars making its way back to the community in the form of more than 60 wage-paying jobs. We're proud of that community impact, and we are proud to serve Illinois' hunger relief system. But in this food system, we have faced a couple barriers. We've often found that Illinois' funding overlooks critical and innovative components of the modern charitable food system. Dollars still tend to flow to a small slice of organizations, while many community-based providers, innovative models, and coordination efforts are left out. At the same time, need is rising. Families are facing higher costs of living and reduced access to federal nutrition assistance, and making more people rely on charitable food programs. And so at Dion Chicago Dream, despite our measurable outcomes, we have frequently been ineligible for state grants because we do not fit traditional criteria. We don't source from a food bank. We buy everything fresh to ensure quality above else. We don't use volunteers, so we can create living wage jobs in our communities. And then along with other eligibility criteria, these barriers have gotten us from receiving funding. So the logistics, warehousing, and technology infrastructure that make our outcomes possible are rarely highlighted, supported, or represented when discussing the bottlenecks in the food system. And with more intentional engagement, these barriers could be avoided. So to quickly go over the bill, HB 5235 directly addresses these challenges, and it modernizes Illinois' approach to hunger relief by recognizing the interconnected roles in the charitable food system and naming them as 5 groups: food providers, distributors, producers, facilitators, and data systems. It also directs state agencies administering hunger relief grants to align their funding with this full ecosystem when possible, so that investments in the food system are getting to all the families in need. And finally, the bill updates the Illinois Hunger Relief Fund, a voluntary individual tax refund donation, which right now these dollars can only go to food banks, even though many other charitable providers offer high quality, consistent access to food without partnering with a food bank. So in short, this bill fills a critical gap in Illinois law and ensures that Illinois' investments align with how hunger relief actually works on the ground today. And on behalf of Beyond Chicago Dream and the communities we serve, I respectfully ask you to consider House Bill 5235. Thank you.
Thank you so much for that testimony, and thanks for being here. Thanks for coming down from Chicago, and thanks for all your work at Dion Chicago Dream. I've seen some good media coverage of your work. DHS, do you want to put some opposition on the record as you all work on this bill together?
Yeah, as Representative Harper said, we are working with her on an amendment. I think our biggest concern is staffing capacity, and that we do currently work with food banks, but I definitely hear the carve out there, so happy to discuss that with you.
Okay, and then just for the record, Rep. Harper, we're gonna hold the bill on second, and we'll see you again in committee with an amendment.
Yes, Madam Chair.
Okay. Do members have any questions? Rep. Ness.
Oh, thank you, Chair. I know you're coming back, and it sounds like you're doing incredible work, and I know that there are challenges in pockets of people that are not getting access to food banks, and I'm in the northwest suburbs, and we have some of those problems too. I guess one of my questions, well, two, it looks like this is subject to appropriation. Is that correct?
There is a portion that speaks about appropriations, but we don't have a specific dollar number, and that's part of what we're working on with DHS.
Okay, so this is some appropriation. And then secondly, I guess, have you tried to work with the food banks to meet the need that you're meeting? Has there been any collaboration?
We have made a conscious decision to purchase from suppliers as an independent organization that works within the Englewood community.
So suppliers like grocery stores and wholesaler suppliers?
Wholesale providers, and we hope in the future to work with nonprofit, wholesale, local food providers as well.
Okay, thank you.
Okay, and one clarifying question for me, because Rep. Harper, you and I chatted about this, but it's my understanding that your intent is really to expand eligibility for a program that's currently on the books, so entities, Dion Chicago Dream just being an example, but entities that are more like Dion Chicago Dream would then be eligible to go after a program and money that has a history of being appropriated. Is that accurate?
That is accurate. Thank you.
Okay, excellent. Thanks. Okay, I'm not seeing any other questions or debate. So Rep. Brielle moves that House Bill 5235 do pass. Do we have leave?
Partisan pending the amendment, please.
Excellent. Partisan leave pending the amendment. 8-4, still 8-4. So that there being 8 votes in favor, 4 opposed, 0 voting present, House Bill 5235 is declared passed and will be favorably reported to the House floor.
Thank you, Madam Chair. Thank you, members.
Thank you. Okay, we got 2 out of 20 down. We are going to move to House Bill 5574, Rep. Guerrero Cuellar. Rep, when you're ready, take it away.
Thank you, Chair. Good morning. Sorry, I was all the way in the back. I didn't know we were coming on to me. Give me 1 second. Okay, so House Bill 5574, this is an effort to create awareness about the program for all-inclusive care for elderly, through PACE. PACE is a cost-effective program that provides community care and allows Illinois seniors to age in their own homes versus being at nursing facilities at a lower cost to the state. And so, however, because enrollment has been lagging, some of the families don't know that the program exists. And so this is to help the program grow and flourish and create awareness because we think it's really critical. I'll stop there if there's any questions. We have Matt here who can answer, but that's the gist of the bill.
Great, thank you so much, Rep. In terms of witness slips, we have 3 proponents. We have Matt Hartman, who you're seeing in the room from PACE Association of Illinois, Nathan Pritzker from OSF Healthcare, and then Ricardo Cifuentes from Esperanza Health Centers. No opponent witness slips. Matt, do you want to add anything to the record on the front end?
In interest of keeping the committee moving, Chairwoman, I am here to answer questions. I think the representative covered what we're trying to do well. This is just a marketing and awareness piece that helps a valuable program.
Excellent. And remind me, because I got distracted at the beginning, I see Spokes Hammond, but you're working on an amendment that we'll see back in committee or not? I just got distracted.
No, on this one, I think this might be the only bill I have that isn't opposed, Chairwoman.
Gotcha. Okay, Leader Hammond.
I certainly don't want to ruin that for you. Is there a cost involved?
I've not been provided with one by the impacted agencies.
Okay, thank you.
Okay. Not seeing any other questions. Yeah, Rep. Ness has a quick question.
What's PACE? What does it stand for?
So PACE is we're not buses. PACE is the Program of All-Inclusive Care for the Elderly. So this is a program, it's existed in the United States for quite some time, but just recently, the last few years in Illinois, we've kicked this off. So this is for individuals who are over the age of 55, who meet the nursing home eligibility levels of need, and who live in specific zip codes, because we're not a statewide program yet. So it's essentially to keep folks from unnecessarily being institutionalized before they need to be. It helps keep individuals in their communities who meet the nursing home level of need of care, but can see those needs met in community at a cost savings to the state.
Thank you, Matt. Rep. Riel has a question.
Is there any plan, and if so, when would that plan go into effect to extend it to other zip codes? I know this is something in our rural communities in particular that is really important, as there are not a lot of senior or affordable assisted living facilities. So,
yeah, so at present there are 5 operational programs, Representative, 4 of them in the Chicagoland area, 1 in Peoria. There are 2 more that are going to be coming online, 1 in the Metro East and another also in Chicagoland area. The Department on Aging actually just released a report earlier this year. It's their Engaging report. It's good reading if you're a policy wonk. The Department on Aging would like to see this program go statewide, as would HFS, but it's a slow growth program. It's going to take time for it to get under its feet. We think measures like this help with that expansion. I would love to see it be a statewide program. I'd love to see it be a rural program as well. So there are long-term plans to do so. As well, recently Congress, in a bipartisan and bicameral way, have both expressed support for states to continue to grow the program as well. So it's something that has a lot of backing in a bipartisan, bicameral way, both nationally and stateside.
will there be a list for districts interested who would like to have the program extended to their area? Because you could put me down on that for the 76th. I'd love to see that out there.
I think the ultimate goal for the agency is to see it become a statewide program, a more expansive program. As of right now, I can't speak to where future projects.
But can I put my name down, like a wait list?
Representative, I can connect you with the right people, absolutely.
Sweet, thanks.
Excellent. Thank you. For the record, no, it's all good. Somebody heard the word Metro East and their ears perked up. I'm just saying for the record, I'd like to talk to you, Matt, not at this hearing, about the life stage of implementation so I can fully understand where these PACE facilities are. It's my understanding there's one a little bit south of my district or it's coming online. So we'll have that conversation later. With all that being said, there's no further debate. So Rep. Riel moves that House Bill 5574 do pass. Do we have leave?
Leave.
All right. So with leave, 12, right? Okay. With leave, we have 12 votes in favor, 0 opposed, 0 voting present. House Bill 5574 is declared passed and will be favorably reported to the House floor.
Thank you, everybody.
Rep. Rep. Moeller, are you ready to move forward? Excellent. We are going to move forward with House Bill 5408, Rep. Moeller. Whenever you're ready, take it away, Rep.
Thank you, Chair. Thank you, members of the Human Services Committee. Today I'm here to present House Bill 4804. There is an amendment that I would ask be adopted before we move on to the substance of the bill.
5408, right? Did she say it wrong? Okay. Okay, excellent. So we've got to adopt this amendment. Rep. Morris moves that the Human Services Committee do adopt House Committee Amendment 1 to House Bill 5408. All those in favor say aye, opposed say no. In the opinion of the chair, the ayes have it. So with that said, we'll let you keep talking, and then I'll do witness slips in a moment.
Okay, great. Thank you so much. And I'm joined by Allie from the Governor's Office, who's here to answer questions and provide additional testimony if necessary. House Bill 5408 is an initiative of the Governor's Office, and it creates a grant program to pay for abortions for underinsured or uninsured individuals in Illinois. The funds for the grant program come from a requirement in the Affordable Care Act that insurance plans that cover abortions beyond limited circumstances allowed by the federal government collect at least $1 from each enrollee per month to cover the cost of abortion claims for their enrollees. Those dollars sit in a separate fund and can only be used for non-Hyde Amendment abortions and no other health care. The bill requires that insurance companies report how much money they have sitting in these segregated accounts, and then at the end of the year, once they have paid for all claims, transfer 90% of what is left in that fund to the Department of Insurance. The Department of Public Health will then use that money to award grants to abortion funds and providers. 2 other states have passed similar legislation, Maryland and California. Part of the legislation that we are considering today requires insurance companies to disclose how much money is sitting in these accounts. In California, there was up to $200 million, and in Maryland, $50 million. However, in Illinois, we do not know how much is sitting in these accounts, and again, that would be part of, that's part of the legislation, is to disclose the amounts that are sitting in these accounts. The insurers would have to remit the funds on September 1st, and that would, September 1st, 2027 is the first remittance, and then every year after that. And again, this is a fairly straightforward bill to create this fund. We know that we have uninsured and underinsured people in our state who need access to this care, and this would provide a funding source for that care that's been that was designated when the ACA was created back in the mid-2000s. So with that, happy to answer any questions, and again, we have Allie here to also provide testimony if necessary.
Thank you, Rep. We'll look at witness slips, but I just want to say, to be extra clear for the record, that we did adopt the amendment, just so everyone hears that. Good. Okay. Okay, we have 4 proponent witness slips, 15 opponents. For proponents, we have Kristen Park. We have Marissa Jackson, Donnell from Planned Parenthood, Great Rivers Action, Mike Ziri from Planned Parenthood, Illinois Action, somebody named Patty Pace Halpin, and then for a flavor of the opponents, a bunch of selves, Illinois Family Institute, Catholic Conference of Illinois, and also the Illinois Life and Health Insurance Council. Leader Hammond, is that a good flavor of the witness slips? Okay, excellent. Allie from the governor's office, do you want to put something on record now, or do we want to see if there are questions? Okay, excellent. Do we have questions or comments from committee members? Rep. Grassi.
I know we don't know how much money is sitting there. Do we have an idea or none at all?
We don't know, and that's part of what this legislation would provide for, to disclose those amounts.
Thank you. I'm in support of all this.
All right, I'm not seeing any other questions. We do have another question. Take it away, Rep. Morris.
Thank you. I just have an example about the insurance. I just want a little more clarity. So if it's $1 million for abortion coverage, right? The actual service paid for was $700,000. So the extra money is $300,000 that will be left over. That $300,000 will be transferred to the state fund instead of being kept as a profit or surplus.
Yeah, so the insurance carriers have to collect $1 per enrollee per month, and then that is used to pay any claims for the non-Hyde Amendment abortions. And then at the end of the plan year, and then I think we have a buffer period as well after all the claims are paid off, using the like what they can pay using claims for their enrollees.
Okay.
All right, excellent. Allie, please fill out a witness slip when you get a moment. Do we have, okay. Let's hear from Kate, and then Leader Hammond, you'll take it away after that.
Thank you, Chair. Members of the committee, my name is Kate Morthland. I'm with the Illinois Life and Health Insurance Council. We respectfully oppose House Bill 5408 as amendment. While we understand the policy goal of expanding access here, the mechanism outlined in this bill raises concerns regarding feasibility and administration within the insurance marketplace. So this bill requires health insurance issuers to track, report, and transfer funds from separate allocation accounts tied to abortion services into a newly created state abortion access fund. However, the industry is really unclear of how this requirement will function in practice, particularly given the dynamic nature of the insurance market. Plans routinely enter and exit into the market. They merge, they dissolve entirely, like we've heard last year with Health Alliance. We're unsure of how this bill will operate within them. Additionally, the amendment introduces a retroactive style financial reconciliation concept that departs from traditional insurance accounting principles, which would create more operational uncertainty here. It applies this reporting and clawback framework retroactively to 2014. Raising questions about how insurance companies would comply as they have priced just for the year. I do want to also mention we're unsure how this will operate with recent CMS guidelines released in 2025 that states that while there is not a full repeal of that segregation, federal guidance has now allowed reintegration of those funds once that plan year has ended, which creates further inconsistency of how this reporting and allocation will happen. In addition, in 2022, the Department of Insurance issued a bulletin which specifically encouraged plans not to separately bill insurers of the $1 premium associated with abortion coverage under federal requirements to avoid that non-payment for premium. So All of this guidance further complicates any attempt to retrospectively reconstruct or reconcile these funds as issuers were operating in accordance with state direction and federal guidance at this time. So we do have a lot of questions. We are working with our members to get some more specific feedback, which unfortunately I don't have at this time, but I really hope that we can continue the conversation and talk about implementation and how this will look in practice. And with that, I'll yield. Thank you.
Thank you, Kate. Leader Hammond.
Thank you, Madam Chair. So, Kate, the question may be for you. I'm hearing $1 from all insured. Is there a separate coverage for abortion in insurance?
So the dollar per member per month is what is billed to the consumer, and then those funds need to be in a segregated account for non-HIDE abortions.
So, all insured, all consumers? Male, female?
Yes.
Are we concerned about constitutionality of this?
This was part of the federal Affordable Care Act that passed.
I understand that. I think we're going somewhere that is challenging. Thank you.
Okay, just a clarifying question for me. The $1 per member per month that has been referenced, that already exists today, correct? This is not, that component of your bill is not new. It is current law, and the Supreme Court has already declared it constitutional. Just want to clarify that. You're nodding, but can you just say yes into the mic?
Yes.
Excellent. People in the back could not see you nodding. Okay. I am not seeing any other questions. So there being no further debate, Representative Ness moves that House Bill 5408 do pass as amended. Is there leave?
Partisan.
Partisan leave. So with partisan leave, there being 8 votes in favor, 4 opposed, 0 voting present, House Bill 5408 as amended is declared passed and will be favorably reported to the House floor. Thanks, Rep. Moeller. Thank you, Governor's Office. We are ready to move to Rep. Stava for House Bill 4700. Take it away when you're ready.
Hello, thank you, Madam Chair, members of the committee. So happy to see you bright and early this morning. This bill is a bill that came to me from the Department on Aging. Right now, we have a definition of long-term care facility that is far too narrow, and it's leaving seniors in certain types of housing vulnerable to abuse and neglect without our oversight and ability to have mandated reporters report cases of suspected abuse and neglect. So current law needs to be changed because specifically residents of assisted living and shared housing establishments, as well as those in supportive living programs, are not covered under our law. So this proposal changes the law by including assisted living and shared housing establishments in the definition of long-term care facility of the Abused and Neglected Long-Term Care Facility Residents Reporting Act. This initiative would not require an immediate effective date, and I think that overall this is a good initiative that we should all be able to focus on because I think we can all agree no one wants seniors to be left vulnerable without any oversight or protection. So thank you.
Thank you, Rep. Stava. We have 4 proponent witness slips, 0 opponents, and the proponents are, of course, the Illinois Long-Term Care Ombudsman Program, 2 witnesses from that entity, and the AARP of Illinois and the Department on Aging. Jessica, are you here to offer proactive testimony, or do you want to just answer questions?
Chair, I'd just like to say that we see this as a technical cleanup. We don't think that there was intention, as we have mandated reporting laws covering seniors and adults with disabilities, to omit people residing in assisted living and shared housing establishments and those in supportive living. And so we're trying, it was one of this like, oh my goodness moments for us when we realized that it was omitted. So we're just trying to close that loop.
Great explanation. Do we have any questions or comments about the bill? All right. I'm not seeing any. So Rep. Moeller moves that House Bill 4700 do pass. Do we have leave?
Yes.
With leave, there being 12 votes in favor, 0 opposed, 0 voting present, House Bill 4700 is declared passed and will be favorably reported to the House floor. Thank you, Rep. Stava.
Thank you.
All right, I think that's 4 or 5 bills down. Rep. Cassidy, are you ready? If you're not, that's okay. Many others that can go.
Delighted to be ready.
Rep. Cassidy is delighted.
Good morning, everyone. Thank you, Chair LaPointe and members. House Bill 4834 continues the work that the Dobbs Working Group has done to ensure that patients and providers of reproductive and gender-affirming care are protected and that their data is protected. This would remove any of the gender-affirming care medications from the prescription monitoring program, a program that has been shown to be abused in the past to seek out folks who are on opioids. We had a bill in this committee around that, our chronic pain bill. And so this continues that work, and it would exempt testosterone, which is currently the only one that is being reported. But because the PMP can be changed by rule, we want to proactively ensure that any of the other meds that are used in this way are exempted from inclusion in the PMP as well. And I'm happy to take your questions.
Thanks, Rep. Cassidy. We have 66 proponents, 2 opponents. For a flavor of the proponents, we have the AIDS Foundation of Chicago. We have Chicago Women in Trades, Spectrum Psychological Services, Disability Housing Justice, Youth Outlook, Citizen Action Illinois, Planned Parenthood, Great Rivers Action. And then for the opponents, we have the Catholic Conference of Illinois and Illinois Right to Life. Is that sufficient, Leader?
And I have a letter from the Catholic Conference noting that their opposition was filed in error.
Okay, and I just got that clarification.
But apparently
from
you
the
can't
back, too.
undo it. So,
Okay. So the Catholic Conference of Illinois did not intend to file against this bill. Do you have witnesses that want to give proactive testimony?
just questions.
Just questions. Okay. Do we have questions from the committee? Okay. I am not seeing any questions. So with that, Rep. Morris moves that House Bill 4834 do pass. Do we have leave?
Partisan.
With
We love you.
All right. With partisan leave, there being 8 votes in favor, 4 opposed, 0 voting present, House Bill 4834 is declared passed and will be favorably reported to the House floor. Thank you, Rep. Cassidy.
Thank you.
Leader Hammond, are you ready to present Rep. Ellick's bill?
Sure, happy to.
Excellent. Okay, so we are going to hear HB 4868 from Leader Hammond on behalf of Rep. Ellick.
Thank you, Madam Chair. This is 4864 is fairly straightforward. Amends the Nursing Home Care Act and requires that each facility notify the appropriate regional office of the Department of Public Health within 24 hours or the end of the next business day after a reportable incident or accident. And there are folks here from Leading Age that are happy to add a flavor or answer any questions.
Thanks so much, Leader. Can clarify for the record, is ongoing work being done on this? Will it come back, or is this good to go in your eyes?
Yes, there will be an amendment that we will gladly bring back to committee.
Okay.
So I'd ask that we move it to second and hold it there. And
Excellent.
I can speak for Leader Ellick that she will do that.
Okay, and it's House Bill 4868 for the
Correct.
record. Looks like we have 5 proponents, 1 opponent. For proponents, we have Leading Age Illinois, Healthcare Council of Illinois, and then 1 opponent on the record, the Long-Term Care Ombudsman. So with that, looks like proponent witnesses are here. Do you want to do proactive testimony?
Sure, we could. Yeah. So I'm Jason Speaks. I'm the Executive Director of Leading Age Illinois. And this is just following up on legislation that Representative Ellick had sponsored for us last year that passed unanimously, but that was in the Assisted Living and Shared Housing Act. We essentially duplicated that language to put it into the skilled nursing facility, or the Nursing Home Care Act. The reason being is that a number of our members were over-reporting, and there is burdensome reporting requirements for things that they were unclear about. We wanted to clarify what they're actually to report, so we kind of spelled that out in this legislation, just like we did last year in the assisted living bill. And because our members previously were reporting things like skin tears and things like that, just for fear of getting cited afterward. There weren't necessarily things that you would have to report. Abuse would be excluded within this. Obviously, that would have to be reported, and that is taken very seriously, particularly with our members. So we are working, there is opposition listed, as you mentioned, but we're working with the Ombudsman as well as IDPH to get them to neutral and satisfy their concerns. And I do have, who traveled down here, our clinical staff person who not only worked, she works with us clinically, but she worked in a nursing home and was a state surveyor as well. So I don't know if you have anything that you want to add since you came down here, but feel free to, Kelly, if you'd like to.
I think Jason covered it well, and so I'll just answer any questions should you have any.
Okay, and what's your name for the record?
Kelly Van Ree.
Okay. All right. Any members have questions or comments? Okay, not seeing any. Rep. De La Rosa moves that House Bill 4868 do pass, but just to be clear, this will be held and we'll be seeing it back in committee. Do we have leave? Do we have leave?
Yes.
Yes, we have leave. Oh, yeah, sorry, I screwed that one up. All right, we're going to backtrack there. Leader Haas moves that House Bill 4868 do pass. Yep. Okay, we're going to pause. Can Leader Hammond or perhaps the proponent witness give us a little flavor? We know you promised to bring it back, but what specifically are you working on?
So there are a couple of components of the bill that we're working on. Just changing some language, so I think the original bill says significant. We're going to change that to serious to better align with the Nursing Home Care Act. And then we're also taking out the or next business day part, just because there was some concern with a delayed reporting, and then making sure that it's clear that abuse is excluded from the language.
Okay, and those are conversations with the ombudsman. Okay, excellent. All right, with that being said, Rep. Haas moves that House Bill 4868 do pass, and we do have a leave. So there being 12 votes in favor, 0 opposed, 0 voting present, House Bill 4868 is declared passed and will be favorably reported to the House floor.
Thank you all.
Thank you. We are going to move on to House Bill 4580, Leader Rita. Someone's going to get him. I believe he's outside the hearing room. We are going to change course here, and we're going to put Cassidy in the chair, and I am going to present the bill on behalf of first Rep. Manley, sorry, Kelly, and then Rep. Kelly, just so we can keep things moving.
Cassidy in the chair. The chair recognizes Rep. LaPointe to present House Bill 5239. Going to do a little, get our witness slips. We've got Allison Nickrent from Illinois Department of Public Health and Greg Willis as proponents, 12 opponents, Ben Lazar from the Association of Safety Net Hospitals, Tim Egan from Roseland Community Hospital, Trinity Perkins, Angelique Trebet, Roseland Hospital, Ann Igo, SEIU Healthcare, National Nurses Organizing Committee, Jackson Park Hospital, Loretto Hospital, St. Anthony Hospital, and Roseland Hospital is showing out in force today, so we've got a lot of you on the slips here. So with that, take it away, Representative LaPointe.
Thanks, Rep. Cassidy. First, I want to be really clear that our intention here on behalf of Rep. Manley is to get this bill out of committee and hold it on second so we can continue to have conversations about the bill. We know that there are many things to be worked out, and you just heard several opponent witness slips. So that said, House Bill 5239, at its core, what its intention on a very basic level is about expanding licensure eligibility for freestanding emergency centers by permitting them to operate in municipalities that have more than 50,000 inhabitants. The bill also would allow, the bill as written right now, the freestanding emergency centers that meet specific federal provider-based criteria to market themselves as hospital emergency departments. So, as I said, Rep. Manley and others are going to continue to work on this bill. We're going to see the amendment back in committee, but those are the basics of the bill. Rep. Cassidy.
Great, thank you. With that in mind, I know folks have traveled to come, so if we could keep the testimony tight and short, because we're going to do it again. Let's do that, whichever order folks want to take.
Good morning. I'm Greg Willis, Legislative Liaison for the Department of Public Health. Thank you, Chair, and thank you, members of the committee. With this bill, again, we're just going to reiterate that we do want to work with the different entities of the Safety Net Hospital Group to potentially amend or get to a more agreeable solution. The purpose of this bill is simply to, like you said, like the sponsor said, to license more freestanding emergency centers. Basically, the bottom line is what this does is it provides better access. As many of you know, emergency rooms, they tend to have long waits. what this does is it will provide a freestanding emergency room that will service individuals that have a lesser, like a lesser, not priority, but a lesser severity of treatment. So only about 10% of all emergency room visits result in admittance within the hospital. So an FEC, or freestanding emergency center, will allow quicker access to individuals to get service and get the care they need. This one point I'd like to make, though, is that these will only appear through when they've been classified, reviewed from HFSRB. They have to show that there is a need and no real duplicative performance of duties from other nearby hospitals. So, in other words, if an area is saturated with plenty of coverage of healthcare emergency room departments, then an FEC would be rejected in that area. So it's to provide more access, as well as in rural areas where that could be problematic for people that live in those areas. So with that brief overview, I'm just going to hold and answer questions as well as let the opponents speak.
Go ahead, Mr. Egan.
Chairperson and members of the committee, thank you, Chairperson LaPointe, Republican spokesperson Hammond, for the opportunity to testify in strong opposition to
I need you to state your name for the record, sorry.
Tim Egan, the president and CEO of the new Rosen Community Hospital. That was actually my next line. We're on the far south side of Chicago. I'm here on behalf of the Association of Safety Net Community Hospitals, which care for Illinois' most vulnerable residents. Patients who are overwhelmingly low income, uninsured, or underinsured, and primarily from minority communities that already face significant health disparities. I want to recognize Allison Nickrent, Deputy Chief of Staff at the Illinois Department of Public Health, whom we had the pleasure of meeting with a couple of weeks ago on this issue. She has always been wonderful to work with, and we deeply appreciate her guidance and collaboration on matters affecting the state's safety net hospitals. Safety net hospitals, by definition, serve patient populations that are more than 50% Medicaid. In reality, most of our hospitals are 80 to 90% Medicaid, with little to no commercial insurance. We are already hanging by a thread financially. At the same time, we are more than hospitals. We are economic anchors. In many of Chicago's poorest neighborhoods, safety net hospitals are among the largest employers and one of the few stable institutions left. HB 5239 is part of a broader effort known as the Moonshot Initiative, an effort driven by outside for-profit consultants with no real connection to Chicago's safety net communities. And from where we stand, this is not a moonshot to improve care. It is a kill shot aimed at the very hospitals our communities depend on. This proposal is not coming from within our communities. It's being imposed on them. Freestanding emergency centers do not provide the full range of services that hospitals do. They do not run inpatient units. They do not sustain trauma care, behavioral health, or other essential services that communities like ours depend on. But they are allowed to compete for the same patients and employees. This creates a simple and dangerous dynamic. They take revenue, we keep responsibility. Safety net hospitals cannot turn patients away. We treat everyone regardless of their ability to pay. This bill weakens that very system that is required to be there for everyone. Freestanding emergency centers are not a neutral addition to the healthcare system. They are a step toward replacing full-service hospitals with limited profit-driven alternatives. They pull away the limited revenue hospitals like ours depend on without taking on the cost of comprehensive care. Over time, that imbalance forces hospitals to cut services, reduce staff, and eventually close. This is how hospital closures happen, not all at once, piece by piece. And when a safety net hospital closes, it's not replaced by a freestanding emergency center. What is lost is far greater: inpatient care, specialty services, jobs, and a critical community institution. Freestanding emergency centers are not hospitals. When patients arise with serious conditions, heart attacks, strokes, trauma, they often need to be transferred. That means delays in care. Patients do not understand these limitations. They see emergency, they expect a full-service hospital. This bill creates a two-tiered system, one that looks like emergency care and one that actually is. In critical moments, that difference matters. Freestanding emergency centers are often backed by private investors. Their goal is not to serve the most vulnerable, it is to generate returns. This model prioritizes profit over patients and weakens the hospitals that communities rely on every day. If the goal is to improve access to care, the answer is not to introduce a model that drains the safety net. The answer is to strengthen it. Invest in safety net hospitals, strengthen Medicaid, expand community-based care. Support the institutions that are already serving these communities every day. HB 5239 will not improve access to care. It will accelerate the loss of it. It will weaken safety net hospitals, put more at risk of closure, and leave vulnerable communities with fewer options, not more. On behalf of Roseland Community Hospital, the Association of Safety Net Community Hospitals, I urge you to reject this bill. Say no to the moonshot. Our communities cannot afford to lose the hospitals they depend on. Thank you.
Thank you, Mr. Egan. Before we get to questions, I'm just going to take a little privilege here and point out, as I was listening to both, I couldn't help but think that what we really need is more primary care in these communities to keep people from having to go to emergency rooms. And I wish that the department was more focused on that than this. First question is for Representative Ness.
Thank you, Chair. And that gives a little bit of a flavor to my thinking as well. I was thinking this sounds like an acute, urgent care kind of setting. My concern is that a consumer is not going to know the difference. You see the word emergency, you think that that's an emergency room connected to a hospital system. And where I understand where this might be, might have a geographic need perhaps in places where, hospitals have closed. We know that, especially in rural communities, there might be a need for something like this. I still think it's something different and not this. And I want to end my comment by saying that we had an issue in my district with a for-profit ambulatory center that went in across the street from a safety net hospital, which, many of us fought hard to not have it go right there, but they strategically placed it right there because they could make a profit there, right? And if we're going to uphold or hold up our safety net hospitals and put the burden on you as you expressed, then I think we need to help protect that as well by looking at some of these policies that do not cross over or remove from what you're already doing. So I do share some concerns about this. I know it's coming back. I don't want to belabor the point, but I wanted to put those points on the record. Thank you.
Thank you.
Leader Hammond.
Thank you, Madam Chair. So I would echo the previous comments that were just made, and also to encourage the department to focus on the primary care needs in our communities. I've quite frankly, I don't understand why this bill is needed if that's our end goal. If that's our end goal, then let's work towards that goal. Let's not create something that shouldn't have to take on the burden that we as a state should be doing and protecting our safety net hospitals. I think that putting these up does give people a sense of false hope and a peace of mind that they probably should not have. And the comment was made that this would be helpful to our rural communities. But as I read this, currently in statute, these FECs are allowed in municipalities with a population of 50,000 or fewer inhabitants. But under this bill, freestanding emergency center may be located in a municipality with a population greater than 50,000. So that does not incentivize more of these in our rural areas. Absolutely, it does exactly the opposite. And quite frankly, in our rural areas, we struggle for health care. We struggle for every aspect of health care: nurses, doctors, specialties, hospitals. So I don't think that this is the answer, and I hope we do better.
Representative Briel. Thank you to everyone. And I would like to echo the sentiment of everyone who has spoken against this. We talk about rural communities. I am from the 76th district, which is an incredibly rural community. The county I live in is the second largest geographic county in the entire state. I would like to say that freestanding emergency clinics have been a large portion of the destruction of healthcare. I have countless calls every month, emails, meetings with people because of the loss of our safety nets, because of the loss of accessibility of healthcare in our area. These are not a substitution. Right now, we're looking at a consolidation of services that left a hospital, still defined as a hospital, with no anesthesia, no OB, no pediatrics, and yet it's still a hospital, question mark, with an emergency room. And these freestanding clinics, as some of the other representatives have said, have no access to those types of services. They have no specialties. People will be transferred anyway, which puts a higher burden on your first responders in order to make it get there, and re-enriches insurance companies for the prices that they pay for transportation. Leaves people an hour to 2 hours away from their home with no one available to get there. So I thank you for bringing up your opposition, and having lived this my whole life, this is a really bad idea. Sorry, no offense.
Yeah, and I'm happy to respond to all of the comments that we've gotten so far. Very much hear you guys, especially about the need for primary care. So very much message received, and that is something we're working on at IDPH. So I'll work on getting some information and sharing it out with members of the committee about that. I do want to clarify that there are only currently 5 FECs in the state. So I don't want these to be conflated with what we all consider, urgent cares, right? Some of those private companies where you can walk in. So they're different because freestanding emergency centers do have to be affiliated with a hospital, and that's for purposes of transfer, right? For that 10% that does need to be admitted, those are admitted to that partner hospital. So just want to say we still hear your concerns. I just wanted to make that clarification as well.
Chairperson, can I put a fine point on this? Oh, Chair, sorry.
Very briefly. I think the horse done been beat, so.
Well, if I could put a fine point on
Yes.
this, Roseland Community Hospital is one of the last hospitals on the south side of Chicago with an OB department. We've held on to that with our fingernails. It is a very expensive unit to run, but I'll tell you why, because I thought it was morally reprehensible to shut down our OB department during COVID like some hospitals did, because babies were still being born. But I'm not just talking about a pregnant mom. I'm talking about the 15-year-old girl who's been prostituted and strung out on heroin and dropped off by her pimp at our emergency department after her waters broke. You do that at a freestanding emergency center that doesn't have maternal fetal medicine experts, that doesn't have neonatologists. Not only you got a dead baby, you got a dead teenager. I see no reason why this gets out of this committee, and I'm begging you to vote no.
Representative LaPointe.
Okay, so we've heard a lot on the record. We have a witness begging everyone to vote no, and you've made a really good case. Just for clarity, I'm here leading this bill temporarily on behalf of a colleague who asked me to do it. We have 20 bills in this committee today. We don't want to be here till 1 o'clock. So I'm going to make the decision to pull this bill from the record.
Thank you.
Thank you. And what's the other one we're doing? We're doing one more bill? You, okay. LaPointe, back in the chair.
Okay. Leader Lilly, you want to step up? And Leader Rita, my best advice is to stay in the committee room. And I say that with love. You are my mentee on the leadership team. He's not even listening right now. Here's what we're gonna do. We're gonna hear one from, we're gonna mix it up because we all need a breather after that. So we're gonna hear one from Leader Lily, then we're gonna flip to Leader Rita. I do see Rep. Davis in the room too, so we know we're gonna do Leader Lily and then Leader Rita, and then we'll reassess. Okay, you've got a few bills, Leader Lily, but I believe we're starting with House Bill 5062.
Yes, this is well, I'm holding this bill, so let's not start with this one.
How about 5258, Leader Lily?
That's perfect.
Great, take it away.
Thank you, ladies and gentlemen of the Human Services Committee. HB 5258 amends the Medical Technical Assistance Center section of the Illinois Legislative Black Caucus Health Caucus pillar. It repeals Illinois Mental Health Workforce Act. Basically, it expands the statutory definition of behavioral health and healthcare providers and clarifies that MTAC as supporting the medical assistant program and the youth care and the current Medicare contracts in Illinois. It requires MTAC to use reports and data provided by the Department External Quality Review Organization on networks adequacy, provides service deserts and health disparities by race and ethnicity to create an annual network recruitment plan. And it repeals the creation of separate funds for MTAC and instead fund MTAC activities through the Office of Medicaid Innovations budget that is embedded in the MTAC office. With that, I do have Heather Eagleson with me to answer any questions.
Excellent. Looks like there's just one witness slip with Heather Eagleton from HFS, and it's my understanding this is an HFS initiative. Heather, do you want to give proactive testimony, or are you here for questions?
I'm just here for questions.
Okay. Do we have questions? Take it away, Leader Hammond.
Thank you. So just for point of clarification, I'm not fully understanding why, if this currently exists, we're codifying it. Have there been audit findings, or why exactly are we?
Not that I'm aware of. Basically, it expands the definitions of behavioral health. In the Act, it says behavioral health and substance abuse, and it expands it to DD and autism services related to the Act. It also reduces duplication efforts. You know, we're required by the External Quality Review Organization by the feds, so we collect this data, and so it's streamlining it for the MTAC.
Okay, thank you.
Okay. Anyone else have questions or comments? Okay. Not seeing any further debate. Rep. Grassi moves that House Bill 5258 do pass. Do we have leave? Excellent. There being 12 votes in favor, 0 opposed, 0 voting present, House Bill 5258 is declared passed and will be favorably reported to the House floor. Thank you, Leader Lilly. We are going to move to Leader Rita. Once you get settled, take it away, Leader.
Good evening, or good afternoon. I have House Bill 4580, and we're still working on this bill. This bill is to fix an audit finding for the Department of Aging, And ironically, in 2016, I actually passed this bill that created the audit finding for the department. So we're working with all the interested parties, HCCI, Department of Public Health, and the Department of Aging, to try to come up with some language that takes the audit finding away but doesn't penalize the nursing home industry, and they will be able to fix that audit finding. So what I would ask is if we could move this out and come back with an amendment that achieves that.
Okay, we're going to check witness slips real quick. We have 3 proponents, the Department of Aging and Age Options. And then for 1 opponent right now on the record, we have the Healthcare Council of Illinois. And just to be clear, you're going to keep working on amendment, hold it on second, and bring it back to committee. Is that right?
Yeah.
Okay.
And I guess I should say I'm the co-chair of the Audit Commission. That was some of our things we've been doing with the department, is to fix some of these audit findings. And then we've come across that some of them need legislative fixes. So we can't figure out why I passed it in 16 to create that, but we'll come up with a solution.
Excellent. Thank you. Do we have any questions from the committee members? All right. Not seeing any. Rep. Brielle moves that House Bill 4580 do pass. Do we have leave?
Leader Rita, never let a good deed go unpunished. Yes, you have leave.
Okay, with leave, we have 12 votes in favor, 0 opposed, 0 voting present. House Bill 4580 is declared passed and will be favorably reported to the House floor.
All right, thank you very much.
Thank you. Okay, we're going to go. Okay. I'm getting some mixed messages, so sorry, it's a lot to manage 20 bills. We are going to go Rep. Stewart, and then we're going to go Rep. Davis. Take it away whenever you're ready.
Thank you. I am here with House Bill 4602, and thank you, Chair and members of the committee. I just do want to give a little bit of brief personal history why I'm got myself involved in this bill, because I know this bill was out last year, and I know that suggestions for changes are incorporated into this new version of it. It's a weird, he's not technically my uncle, but he's my cousin's stepfather, because we lost my uncle actually before the two of us were born, and so the man that my aunt remarried. But his name is Dr. Art Van Zee, and he is a small town country doctor in Virginia. He's actually featured in the book Dope Sick, which brought attention to the opioid crisis, and OxyContin especially, because he was seeing very healthy young kids, teenagers, being brought in with their grandparents and parents with these opioid addictions. And he was part of getting the FDA to look at OxyContin closer and to make changes and to do the things that we've done. And part of why we have a prescription monitoring program at all is because of the work of Dr. Art Van Zee, who is again, a family member. And if you've never read the book Dope Sick, highly recommend it. It's not uplifting, it's sad, but it's a very good book that goes through that problem. As you're aware, we have a prescription monitoring program. And again, if we could go back in history and when we decided to do this to make sure that people were not able to doctor shop and get multiple prescriptions for multiple opioids at the same time, if we had maybe done this differently as a country as a whole and had one single portal for that, we probably wouldn't be where we are now. But what we're facing right now is, in Illinois, we have some states that are not fully sharing their data with us.
So it's making the PMP not really work the way that it's supposed to. So what my bill proposes, and basically, is that if you're not going to share with us, we're not going to share with you. To be that simple about it. I just think it's really important that we get the PMP to work the way it's supposed to. It really is a public safety issue, I have witnesses and people here ready to testify about it. I know that there's opposition. I know IMRF is in opposition. We've spoken a couple times, and I appreciate. And as always, I have worked with IRMA. Sorry, my previous bill was IMRF. I've worked with IRMA on many topics, and always willing to keep the discussion going. But that's my introduction. Thank you.
Thank you, Rep. Stewart. We're going to look at witness slips. We have 3 proponents and 3 opponents on the record. The proponents are C&G Consulting Partners on behalf of a company called Logicoi, somebody from Leap Orbit, LLC, and another witness for Logicoi. And then opponents, as you mentioned, we have IRMA, we have the Illinois Pharmacists Association, and then we have Max Strategies on behalf of Bamboo Health. Just to clarify, are you actively working on any amendment that you intend to bring back to committee? What's the status of that?
I don't have any proposed amendment language. I am always open to working with people. And so if there's an amendment to be had, I clearly would bring that back to committee. But I think this is something that we have to keep moving. Because like I said, it's really a public safety issue.
Okay, thank you for that. Looks like you have witnesses that want to give proactive testimony, so I'll let the proponent and then opponent take it away.
Chairwoman, members of the committee, my name is Cecilia Hylack-Reinholtz. I'm here representing Logicoi, which is the Illinois PMP provider. As Leader Stewart discussed, when the PMP program was first started many years ago, it was started as a way to ensure that people weren't crossing over borders and getting opioids from other doctors. And it worked for years until people decided to monetize it. There are four main providers nationwide. One is Bamboo, and I represent Logicoi. And what we've found is that Bamboo-specific states have stopped sharing data with us. So right now, Indiana, Iowa, Michigan, and Missouri do not share their data with Illinois, but we share our data with them. So there's really nothing we can do as a body to force another state to data share. When this bill was heard last year, Indiana actually submitted written testimony saying, you can pass this, but we're still not going to data share with you, which was surprising to me because at the end of the day, it's great that as Illinois, we're willing to help protect their residents, but they're clearly not willing to help protect ours. We did work with opposition to include language regarding one-to-one connections. That is in this bill. Once that change was made, we thought, great, we can move forward, but then it was brought up that they were worried about the data not being secure. I've talked to a lot of you. I am not a technology type person, but I would presume if Illinois can send the data out securely, we should be able to accept it in securely. So I'm sure the powers that be can work that out that understand technology more than I do, but it just doesn't make sense that if it's able to be securely transmitted one way, it can't be securely transmitted the other. And I agree with Leader Stewart, this is an issue of public safety for our citizens in Illinois. Thank you.
Thank you for that. We'll go to the Illinois Retail Merchants Association.
Thank you. I know nothing about IMRF, so I can't even make it up. Thank you, Madam Chair. Rob Carr Illinois Retail Merchants Association, and Representative Stewart's correct. We've worked on a lot of issues, and we'll continue to work with her on this one. We do share the same goals. We want safety. The problem is in history. Illinois chose a different path than every other state. They created an island unto themselves, funded by federal grants at the time that most other states refused because they didn't like the strings. Illinois has long tried to dictate its own approach onto other states. That approach has been rejected, and I think that reading the letter from Indiana is telling because of the restrictions that Illinois is trying to put on these other states. We actually want more robust sharing. We want that kind of cross-border interaction that is not occurring today because of the hurdles Illinois PMP puts in place. Other states have rejected the approach that the Illinois PMP has taken. They don't find it as secure, they don't find it as thorough, and they rejected it. From a pharmacy standpoint, the Illinois PMP approach is horribly inefficient because it is not within the pharmacist's workflow. We have to log out of the system we're in, log into a different system to enter and gather information, and then log back in. It's horrific. Interestingly enough as well, while you look at this language and the proponents suggest that one-on-one, it also allows it to be defined by the department. That eviscerates the assurance because the department then gets to define what that sharing looks like from the state of Illinois. That is not one-to-one sharing. That is one-to-one sharing defined how Illinois wants to define it, which from past history is counterproductive. I would also add there's an RFP coming up on this, I believe next year. This would eviscerate the need for that RFP, which we think ought to be a robust RFP so that there's a full, transparent public discussion of those strengths and weaknesses of the various approaches. So we share the common goal. We disagree about where Illinois stands and what is going on today.
Thank you for that. I know Rep. Cassidy has a question.
Thank you. I don't know which one of you might have this answer. Is there anything stopping us from stopping sharing now? It's my understanding, no, because other states, Missouri's never really shared with other states. It's not just Illinois. So it would be a departmental decision to just flip the switch to stop sharing currently. Given what we talked about in the previous bill and the concerns over some of this information, the testosterone prescriptions specifically, I would very much like it if anybody's listening out there in PMP land, flip the switch, people. I don't like getting in the middle of a business beef, honestly, because that's what this feels like. I'm going to support the bill to keep it alive, but I would like us to figure out both of these problems. I don't like doing legislation to end run an RFP. That seems problematic as well. So I can't promise I'll support it on the floor, but I'm going to support you to keep this alive. But I'd like your help getting this turned off until we get testosterone off of there too.
Rep. Moeller.
Thank you. Probably more of a comment than a question. Similar to Representative Cassidy's concern, I know that this is a bigger issue that involves a number of other stakeholders. So I would encourage more conversation and incorporating some changes based on conversation to address that, making sure that the RFP process is meaningful and competitive and that we're getting, the best value and service for our resources, and also, bringing up the privacy concerns that might be out there because of federal, legislation, federal action. I think is really important. So, would encourage that as well, and hopefully we can come back with an amendment that addresses those issues.
Okay.
Thanks.
Thank you, Rep. Moeller. We're going to go to Leader Hammond, but I have two clarifying questions, and I hope these are very short. Rob, when you are using the word the department, which department are you talking about?
Human Services
Human
oversees
Services?
the Illinois PMP.
Okay,
Yes.
and does that mean it would be DHS that's slated to put out this RFP?
That's as I understand it, correct.
Okay.
Yeah,
Just
I'm
wanted to
not an
clarify.
expert in RFPs, but that's how I understand it.
Okay. All right, Leader Hammond.
Thank you, and truly more of a comment. And Leader Stewart, I understand what you're trying to achieve here and why. I think that there comes a point in time where you give and you give and you give and you give, and you see nothing to help you in return for that. So I'm hopeful that you can get together with the folks at IRMA and at least try to find some kind of a common ground here, because I mean, we are pitting this against business, and nobody wants to do that. And quite frankly, it shouldn't be this way. So I don't know what Illinois did when they did it and why they did it. I think there was a lot of things that Illinois has done that I don't know how the hell they did it, but they did it. So I'm hopeful. I see what you're trying to do, and I will help you through this committee, but I'm hopeful that you will also continue to work on this. Thank you.
Yeah, I will. And I think to your point, this is part of a larger issue that our healthcare has been able to become someone's profits. And that's a larger issue that we obviously cannot fix in this committee and with one bill or even in just this one state. But I think this is just an evidence of why that's kind of problematic across the board. But as always, I will always continue to work with people and hopefully find a way to achieve what I think is really important to make sure that we get the full data that we need to protect people. And I care about protecting people from Missouri and Indiana, even if they don't care about protecting people from Illinois.
Thank you, Rep. Stewart. Because of the various sentiments on the bill, as chair, I'm asking you to continue to work on it, which you're already going to do, and work on an amendment that we would hold the whole bill on second. You'd bring it back to committee. You're nodding, so thank you for that commitment. And with that, because we've heard a lot of discussion, can you just pinpoint a few things that you think would be in the forthcoming amendment?
I don't know. I mean, there's a lot of different discussions. And again, I think part of this is, again, the profit and businesses being involved. And I don't really know how to thread that needle. But I think in the making sure, as Rep. Mueller said, that we are going to have an RFP process that actually looks towards, like what's the best choice for the state of Illinois and what will provide what we need from other states is something that we should make sure that we look into, and that could be something that is part of what's brought back. But there's, like I said, there's so many moving parts and so many discussions. I don't know if I can pinpoint much more than that.
Okay, I think that was sufficient. Appreciate that. Not seeing any further debate, Rep. Ness moves that House Bill 4602 do pass. We know it's going to come back to committee. Do we have leave?
Roll call, please.
Okay, with roll call, we'll have the clerk take it away.
LaPointe,
Yes.
Hammond,
Yes.
Brielle, Cassidy,
risk by not sharing well over there. And I have a problem with that.
Moeller. Morris. Ness. Schmidt.
With 10 votes in favor, 1 opposed, 0 voting present, House Bill 4602 is declared passed and will be favorably reported to the House floor. Thanks, Rep. Stewart, and to all your witnesses. Rep. Davis, come on up.
Good morning, Madam Chair, minority spokesperson, and members of the committee. As promised, I am back before we begin. I'd ask to adopt amendment number 2.
Okay, excellent. So, Rep. Moeller moves to recommend that House Floor Amendment 2 to House Bill 4584 be recommended for adoption. All those in favor say aye. All those opposed say nay. In the opinion of the chair, the ayes have it. Okay. It's a floor amendment, not a committee amendment. That's my bad. I used the wrong terminology. So Rep. Moeller moves to recommend that House Floor Amendment 2 to House Bill 4584 be recommended for adoption. Does anyone have anything to say about that House Floor Amendment 2? Leader Hammond.
I think it's a great amendment.
Me too. Okay. Okay, now you get to present House Floor Amendment 2.
Thank you. What this amendment does is it clarifies the workers who would be provided or who would be required, my apologies, to um, take this training. So we heard you. This is direct language from the department. They can speak to their position after that, but we're hoping for an aye vote on the amendment. Thank you.
Okay, now we have to officially adopt the amendment now that you've told us about it. And Rep. Davis, can you confirm that House Floor Amendment 2 removes opposition so we don't have to hold another amendment, but we're good to go now?
Yes.
Great. Okay. So, okay, Rep. Moeller moves that House Floor Amendment 2 to House Bill 4584 be recommended for adoption. Do we have leave? Okay. With leave, we have 12 in favor, 0 opposed, 0 voting present. House Floor Amendment 2 is recommended for adoption and will be favorably reported to the House floor.
Okay. Thank you, guys. I appreciate it.
Okay. For the record, for some reason that was way too confusing, but you're good, Rep. Davis, but I just do want to read some witness slips into the record. Just for the record, we have 8 proponents and no opponents. And no, sorry, we have 1 no position, which is DHS, and 8 proponents. and the proponents are SCIU Healthcare, Clay County Health Department, Effingham Health Department, the Alzheimer's Association. I see Leader Hammond nodding, so we're good. Those are in the record. Thanks. We're going to go back to Leader Lilly now. I believe 2 more bills from her. Is it this one right here? That one first.
Madam Chair, just one more.
Oh, one more left from Leader Lilly, House Bill 5466.
Thank you, ladies and gentlemen. Please. House Bill 5466 amends the Community Behavioral Health Care Professional Loan Repayment Program Act to refine eligibility and renew requirements for behavioral health professionals in underserved and rural areas. I have Catherine with me today to answer any questions you may have about this fantastic bill.
All right, we're going to read witness slips here. We have 2 proponents, 0 opponents, 0 no position, and the 2 proponents are the Illinois Student Assistance Commission and the Community Behavioral Health Care Association. Do you have any witnesses that want to give proactive testimony?
Catherine is with me. Please proceed.
I'm happy to just answer questions if the committee would prefer to be able to move on. But glad to say more if people would like that.
Excellent. Do committee members have any questions or comments? I'm not seeing any. I will say for the record, as Catherine knows, that I am a big proponent of the Community Behavioral Health Care Professional Loan Repayment Program. And if you have not shared this information in your districts, on behalf of me and Leader Haas and everything we do in state government, please share that information because our frontline behavioral health care professionals deserve to have access to the student loan relief. So thanks, Leader Lilly, for shepherding this bill.
Anything for you, Chairman LaPointe.
And we can tell you're a true champion because you were able to say the entire title without looking at it, which is extremely impressive for this program.
Okay. So there being no further testimony or debate, Rep. Grassi moves that House Bill 5466 do pass. Do we have leave?
Yes.
Okay. With leave, we have 12 votes in favor, 0 opposed, 0 voting present. House Bill 5466 is declared passed and will be favorably reported to the House floor.
Thank you, ladies and gentlemen. Keep up the good work.
We are ready to move to Rep. Favor Dias. I believe the rep has 2 bills in committee. Let's start with 4606. Take it away when you're ready.
Good morning, Human Services Chair LaPointe, members of the committee. Thank you for the opportunity to present House Bill 4606. I am bringing this amendment. We've already heard the bill. This is the agreed upon amendment that I am bringing back to hopefully fully pass on to the floor. It is gut and replace, and it brings DHS to neutral. It keeps the House Floor Amendment 2 keeps the intent of the bill, which should I have adopted the amendment? We can do that afterwards.
You're good.
Okay, thank you. House Floor Amendment 2 keeps the intent of the bill, which is for the Department of Human Services to design and implement an infrastructure and administrative home for evidence-based programs as they develop around the state. It builds on the recommendations of the Early Childhood Comprehensive Systems Grant Report authored by DHS. It updates the amendment, updates the purpose of the section to authorize rather than establish the DHS to identify, develop, and manage the administrative infrastructure. It also states that DHS by January 1st, 2028 may do the following instead of shall do the following. It may create and maintain a list of the voluntary universal newborn home visiting models that align with the state's priorities for approach and establishes the requirements for any universal newborn home visiting system that is adopted at the local level. They may coordinate with relevant state agencies, and they may consult, coordinate, and collaborate with relevant stakeholders when designing the infrastructure to support universal newborn home
visiting services. Again, as a review, these are local programs that our local communities are creating. It is not mandated at the local level, and it is also opt-in for families who want to participate, but it is not mandatory. Again, this amendment brings the agencies to neutral. And happy to take questions. Thank you.
Okay, for witness slips, we have 26 proponents and 1 no position. In terms of proponents, we have Lurie Children's Hospital, Public Health Association, Illinois Public Health Association, Start Early, of course, Prevent Child Abuse America. That's the flavor. And then I'm just intuiting that the no position is DHS. Yes. Great. I was right. Okay. Do we have any proactive testimony, or do you just want to answer questions?
This is Jonathan Doss from Start Early. Thank you for hearing this amendment today. I know it's a busy schedule. Happy to answer questions, and just wanted to put on the record our appreciation working with Kelly Hubbard and others at DHS to get to a neutral position. It's been a really great partnership.
Thank you, Jonathan. Rep Meyer.
Just want to clarify a few things. So in this bill, you are putting a program together, and newborn mothers, are you contacting them, or are they being given something at the hospital saying, hey, if you would like services, this is it, or how's this going to be?
So to be clear, DHS is not putting a program in place. It is creating, it may create guidance and evidence-based, have evidence-based practices available for local communities that want to do that. There are 6 counties, if I'm remembering correctly, the city of Chicago, and then 6 counties around the state that have this home visiting program. And so this DHS would help support new local programs. So that, just to be clear, the state is not doing this as a program. In those local counties, they have flexibility to adopt the model that they want. But what is happening in many of those local jurisdictions is that information is being shared with the families in the hospital at their bedside, and then they can, if they would like to have that home visiting check-in at about the 3-week mark,
then they can.
And will this program, if it expands, will it be offered to other, even pro-life agencies that promote life and carrying that child and having birth? Will they have the opportunity to say, hey, if you're having any difficulties, will this be there to help those newborn mothers also?
This is Jonathan Das from Start Early. Typically, when communities adopt this approach to offer a universal postpartum home visit, it's offered, as we've said, in the hospital setting where a nurse will come after delivery and offer it. It also can happen at home births if those communities are organized in that way, and in other birth settings, depending on the locality and the model. There's nothing in the bill specific about exactly where it should happen other than a hospital, but it sort of depends on how the local community organizes itself.
So local pro-life agencies could use this program also, saying if you're a newborn, if you have a newborn and you need help, these services are there to help you ask questions about rearing a child. If you don't have a mother or a grandmother close to you and it's your first child, I'm just, this is one of the things that's been used against us, that the state of Illinois was forcing people into homes and checking on newborns. And I looked at it as this was a way that all people in favor of birth would have access if they had any troubles during those first 3 weeks or 4 weeks before going back to seeing their doctor. Those services, this is just a way of expanding, somebody saying, hey, we'll help you if you need it.
Absolutely. So it is, again, it is opt-in, to be clear. No family has to participate. And so I think, the model is adopted at the local level. And so that local agency that is working on it, I'm sure would be happy to distribute the information about how families can get support 3 weeks post-birth if they want it.
If they want it, yes. It's not something being forced upon them.
Not at all.
Nobody's being forced in their house.
Correct.
I just like to say, we know how politics is.
Yes. Thank you. Okay. And Jonathan, please do a witness slip for oral testimony. We have you on there, but not for oral testimony.
Oh, I apologize.
No problem.
Leader Hammond.
Uh, Thank you, Madam Chair, and really just more of a comment. And um, we were in support of your bill in the past, and we'll be going forward. And I just want to say that it's very unfortunate when you have a piece of legislation like this that is meant to help a population, in this case, mothers of newborns and perhaps even their newborns. And it is totally voluntary for groups to take the ignorant approach and try to put fear and scare into people that people will be pounding down their doors and entering their homes without permission is truly unfortunate and is a very sad state of affairs for our state and others. Thank you.
Thank you, Leader Hammond. I could not agree more. And thinking about after I gave birth, I had a very positive experience and a very collaborative relationship with my nurses and my doctors. And they were there to offer support, and this is another tool that they can help communicate for really a really fragile time in a family's life. Thank you.
Okay, I'm not seeing any more debate. So with that, Rep. De La Rosa moves to recommend that House Floor Amendment 2 to House Bill 4606 be recommended for adoption. Do we have leave? All right. With leave, there being 12 votes in favor, 0 opposed, 0 voting present, House Floor Amendment 2 to House Bill 4606 is recommended for adoption and will be favorably reported to the House floor. Thank you, Rep. And we can move on to your next bill.
Great. Thank you, Chair and members of the committee. I am pleased to present House Bill 4728, which deals with providing services for one of our most vulnerable populations, and that is those with intellectual and developmental disabilities. Historically, services for people with IDD were delivered through a fragmented but community-rooted network of regional nonprofits, faith-based organizations, and local providers. Over the past decade, though, that landscape has changed dramatically. Between 2013 and 2023, there were over 1,000 private equity acquisitions of disability and elder care providers, and that figure is likely an undercount. Many private equity-owned companies operate through subsidiaries under different brand names, making it difficult to trace ownership back to corporate parents and making the whole system more opaque. For example, Alpine created Mentor/TSG as a platform in 2015 and has since acquired small regional providers across the country. Today, it operates at least 12 different IDD and home care brands, but none of those disclose any affiliation with their parent company on their websites. Private equity firms, typically the goal is typically to double their investment within 4 to 7 years. And to achieve these returns in a human services environment, cost-cutting tactics can include reducing staff, failing to provide adequate employee training, underpaying workers, cutting services to residents, and failing to maintain facilities. One of the largest private equity-owned IDD providers states plainly in their financial filings, we are well positioned as an acquirer for small operators in a highly fragmented industry. We continue to maintain a robust acquisition pipeline and deploy capital in a disciplined and opportunistic manner. Are we talking about returns on investment here, or are we talking about people and the care that they deserve to receive? Perhaps the most notable example has been Broadstep, whose record illustrates what is at stake when this accountability is absent. Between 2021 and 2023, the state of Illinois paid Broadstep over $23.6 million for SILA services. An audit by the Office of Inspector General for IDHS found that Broadstep violated both state laws and state rules, including 22 instances of non-cooperation with investigators. In July 2024, the Illinois Division of Developmental Disabilities revoked Broadstep's license to operate as a SILA provider. And we know that that was more than just a revocation of a license. It was people who were left without care. It was families who were having to scramble to find for another place for their loved ones to go, and it left workers without an income. The division cited serious ongoing deficiencies. The human cost of Broadstep's failures fell on 2 groups: individuals with IDD who lost stable housing and the direct care workers without jobs or answers. Today, House Bill 4728 seeks to put guardrails around disclosures and reporting for our IDD providers. In the bill, private equity is treated very differently than not-for-profit providers. And so the goal of the bill is to have a mechanism for which private equity providers are mandated to report their financial status and dealings on initial application and then on a quarterly basis. Not-for-profit providers will have to provide financial information upon that initial application, but that is it. We're asking today to hold this bill on second as we continue stakeholder conversations. Happy to take questions. Thank you.
All right, thanks. We will look at the witness slips. We have 6 proponents, 2 opponents. The proponents are SCIU Healthcare, AFL-CIO, Equip for Equality, AFSCME Council 31, something called the Private Equity Stakeholder Project. And in terms of opponents, we have Bill Dwyer from Helping Hand and Vicki Keene from Don Moss and Associates.
And Chair, if it's possible, Chris Noble from the Private Equity Stakeholder Project is here to provide some testimony, and then we're happy to take questions.
That is okay, but Chris, I'm going to say 2 minutes. We had 20 bills in this committee. After this, we have 3 more. We have 10 o'clock committees. This is very, very challenging. Having said that, we are glad you're here, so if you could keep it to 2 minutes, that would be great. Thanks.
Thank you very much, Chair. I will be brief. Good morning, and thank you, Chair LaPointe, Leader Hammond, and members of the committee. I am Chris Noble, Policy Director from PESP, the Private Equity Stakeholder Project, which is a nonprofit financial watchdog organization that seeks to bring transparency and accountability to the private equity industry for the benefit of impacted communities and investors. The bill sponsor already gave a lot of the examples, so I'll leave some of those out for brevity. But we appreciate this opportunity to testify in support of SB 3118 and HB 4728, as we believe they would strengthen oversight over private equity and hedge fund ownership of intellectual and developmental disability services companies. By updating the state's regulatory framework and establishing guardrails to safeguard services for people with developmental disabilities from predatory investors, Illinois would become a leading example for states seeking to protect their most vulnerable residents and patients. Private equity firms have increasingly set their sights on companies that provide a wide range of IDD services and supports, such as residential facilities, home care, fiscal intermediary services, adult day programs, and occupational and physical therapy. Large asset managers are quietly acquiring and consolidating what were previously small independent firms. Through recent buyouts and consolidation, several large private equity-owned companies have emerged with tens of thousands of employees at numerous locations across the United States. In some cases, these companies have achieved regional market concentration, obscured by complex ownership structures and disparate branding. Several private equity-owned providers of services for individuals with IDD have faced criticism, investigations, and in some instances, closures over poor patient conditions. In March of last year, we released a detailed report about private equity and IDD services that highlights these concerning track records. Also, lawmakers, journalists, and regulators have honed in on private equity firms because of the unique business model that comes from the strategy, which is driven by the search for exorbitant profits combined with very limited transparency and regulation. As the sponsor mentioned, firms typically seek to double or triple the value of their investment in 4 to 7 years, which is challenging to do in IDD services without cutting costs in a way that compromises the quality of care. In the sector where companies provide such encompassing and essential services, private equity's entrance threatens to exacerbate the social and health inequalities that people with IDD already face. In closing, given the industry's track record in the state, excuse me, I have some voice troubles. This legislation presents a timely opportunity for Illinois to rein in the growth of private equity buyouts in IDD services. Vulnerable patients and their families should not have to bear the costs associated with private equity's relentless pursuit for short-term profits in healthcare. PESP therefore reiterates our strong support for both bills. In recent years, states across the country have moved to address private equity's negative impacts in healthcare, demonstrating how widespread of an issue it has become. This legislation would be an important addition to the legislative movement because it is the only one to actually focus on IDD services. By strengthening ownership oversight of such services, Illinois can join the growing chorus of lawmakers that are choosing to prioritize the long-term health of its citizens over short-term profits. Thank you.
Thanks so much. And Rep. Favor Dias, is there a commitment to Okay, thanks. Rep. Meyer, go ahead.
First off, I'd like to be a chief co if there's a spot for this. I have noticed with my battles with DHS, the worst CILAs are usually privately owned, for profit, and they are the ones where we have residents sitting in the middle of the streets. They are the ones why I have to continually run bills. They are the ones that I have the emergency bill out there trying to define emergency, because when we report these emergencies that police have been called, they sit on a file on a stack in DHS yet, because nobody knows the definition of emergency. They don't know if they need to investigate, because there's 30 calls in 1 month to a CILA. But we usually find they are owned by for-profit agencies, not for-profit. So add me as a chief call.
Thank you, Rep. Meyer.
Okay, I'm not seeing any other questions. For the third time, because I'm being asked to confirm.
We are holding it on second.
All right, great. I have some questions, but I will save them for outside of this setting. Okay. So there being no further debate, Rep. Ness moves that House Bill 4728 do pass. Do we have leave?
Yes.
Okay, with leave, 12 votes in favor, 0 opposed, 0 voting present. House Bill 4728 is declared passed and will be favorably reported to the House floor.
Thank you.
Thank you. We're going to go to Rep. Meyer now. We have 3 bills left. So we're going to go Rep. Meyer, and then I'm going to present a bill on behalf of Mike Kelly, who could not be with us today, and then I'm going to present a bill from myself. So Rep. Meyer, when you're ready, take it away.
Yes. 5458 is a simple bill. Should not even be in committee. I know DHS stands against it. They say that this may hurt the ability of them to try to move residents from SODCs into the private sector. I think it does just the opposite. Our parents, our guardians of their loved ones sitting in there, all they want is for their child to live the most normal life. They want them to be out in the community if they can. But right now, DHS, if you do not sign a letter before you move your loved one out of there, you will be in courts, you will be hiring lawyers, and it may take you months if you ever get your child back in an SODC. If they truly believe they have found the best placement for your child or loved one, and it's going to work, they should have no problem with saying it's okay to come back. You shouldn't have to sign a letter. All they should say is, let's try it. If it doesn't work, come back, maybe we'll look again. But this policy of forcing these families back into court to get their loved one where they know they have safe care, when they put it in the facilities like we were just talking about, and it didn't work. So all I'm asking is for, they should not have to go through court again. If the resident had been in an SODC and community settings failed, let them go back there, let them try again. I believe this is a way of maybe getting more of them moved into us because they find a good one. Thank you.
Thank you for that, Rep. Meyer. We have 53 proponents and 3 opponents to the bill. And for a flavor of the proponents, we have parents and friends of a handful of SODCs like the Ludeman Center and the Murray Parents Association, Friends of Choate, for example. And then for the opponents, we have DHS, we have the ARC of Illinois, and then we have our Illinois Guardianship and Advocacy Commission. Do we have any proponent or opponent witnesses in the room who want to make proactive testimony? Not hearing any. Do we have questions or comments from committee members? Rep. Ness.
Well, I understand the intent and what you do in this space, and I'm inclined to, trust what you're bringing forward to us and the need for it. I'm curious from some of the opponents if it's possible to have somebody state what is the opposition to this. Is this a guardian against individual thing? I just would like a little more on that.
Thank you for your question. My name is Beth Johnson from DHS, and I do want to acknowledge Rep. Meyer and your ongoing commitment to supporting individuals with disabilities and their families. I think to answer your question, the goal, our concern is really that the process is already available for individuals that for a path back to an SODC for former residents if the needs and the consent of the individual align. And specifically about the guardian, the agency is concerned also along those lines that it makes the process easier if the guardian requests the placement, like you said, which trends in the wrong direction though, for the agency's goals, and trends in the wrong directions that DHS has made in trying to divert individuals from more restrictive settings and institutional care. So that would be the concern, but we really appreciate the sponsor and his commitment to doing, what he can for the individuals there.
Is there a pathway if a person is seeking if a family and an individual is seeking readmittance, do they have to go to court as the representative stated?
I'm assuming so. I defer to GAC, but yes, I believe that is the way that the process goes. And so this bill would give the guardian, if I'm understanding it correctly, the guardian more an easier path than that, but yes, that's correct.
I guess I can see and without any judgment or understanding about, and I know the long-intended state goal to move people out of SODCs in particular. And I also understand that there may be cases where, it is an appropriate choice for a family. It does seem onerous to require a family in situations where there's not a lot of disagreement about a person wanting to go back, that they would have to go through court. I
will say that the process, if the individual is in agreement, then there's not a concern in having to do that. It's only if, as I understand it, the individual and the guardian disagree, perhaps. Or if the guardian wants it and if they're in agreement, so the individual can go back with the guardian and the family, but the concern with the bill is just that position where if the individual wants to, there's no court that I understand, but I could be wrong, and so I can look into that and follow up, but yeah.
So maybe it's possible that there's a pathway to move this on second and keep working on it. I just want to put that out there for the
I don't believe there is a pathway to put it on second and hold, because what I'm hearing here may be the law, but it is not being enforced by DHS. I've been working with a family whose child was in Isilla, and then he spent 18 days in restraint in an emergency room. Things like this, when Isilla fails, and then they're going to have to go to court to get a child back into an SODC. This is wrong. If they qualified for it before and the Scylla fails, why do you put that family with the family from Taylorville? We were in court 9 times with DHS to get placement. 9 times. This is simple. That child qualified for it before. That child wants to be there. If there is a difference, then let it go to court. But that guardian or that nonverbal child, they should have the right to go back there if they agree. They should not have to go to court. What you're saying may be the law, but it is not what DHS is forcing. So let's clarify it. Say if they've been in an SODC, they're in a Scylla, it's failed. They both agree DHS cannot stop them from going back into an SODC where they're safe. Plain and simple. I don't care what the law says. I know what DHS is doing, so let's clarify the law right here.
All right. Thank you for that. I'd just like to clarify that there are no children under 18 at SODCs, because we just heard the word child being referenced. Bess, can you answer that question?
Yes, I can. To me, they're all my kids. They're a child. They're somebody else's child. That parent loves them. A lot of them have the mentality of a 6 or an 8-year-old, somebody a year-old. So I call them a child, and they're just like my adopted kids. That's why I call them a child.
Excellent. Thank you for clarifying that. I think people without that context might walk away if you hadn't clarified, thinking that people under 18 are at SODCs. So thank you, Rep. Meyer. Any other questions? Okay. Not seeing any more questions. Rep. Hammond, Leader Hammond, moves that House Bill 5458 do pass. I'm looking around at my committee members to see if we have leave. I'm not seeing any. We're going to stand at ease for a moment. So we do have leave to get this out of committee. So with that, there being 12 votes in favor, 0 opposed, 0 voting present, House Bill 5458 is declared passed and will be favorably reported to the House floor.
Thank you.
Thank you. Now we're going to put Rep. Cassidy in the chair. And I believe we're going to start with House Bill 5193. So if you're here as a witness for that bill, please come up to the table.
Okay, Cassidy in the chair. Chair recognizes Rep. LaPointe to present House Bill 5193. We've just got a few witness slips. Heather Wire-Vaught on with oral testimony on behalf of the DuPage County Health Department. Colin DeLau from Endeavor Health, Heather O'Donnell from the DuPage County Health Department. Two opponents, Ariel Hernandez, National Nurses Organizing Committee, Illinois National Nurses United, appearance only, and Mark Paskovich, Illinois Psychiatric Society, appearance only. Take it away, Rep. LaPointe.
Thank you so much, Chair. Just to be clear, as a reminder, this is a bill from Representative Mike Kelly, who couldn't be with us today. So I'll give a brief overview, but we have a lead proponent who can say more. So super brief from me. This is an initiative of the DuPage County Health Department, which some of you might know operates a crisis recovery center. And the CRC is for people in mental health or substance use disorder crisis. The center has a safe sobering unit, withdrawal management beds, etc. I was able to visit that CRC in the summer. I remember it was hot. Okay. This bill deletes some outdated language because currently on the books there is basically the bill deletes language to make clear in law that EMS would be allowed to transport a person who is under the influence of drugs and alcohol, and if the person wants support at a mental health facility that's contracted with the EMS system, this bill makes clear that even if they are under the influence of drugs and alcohol, if they want to go to that facility, it is fully legal and they can. And so I'll leave it at that because we do have a witness that can add more color if necessary.
Thank you, Representative LaPointe. Heather Wire-Vaught on behalf of DuPage County Health Department. It's exactly what you just described. So right now, EMTs, if they're picking somebody up and the person is intoxicated, under the EMT law, they are prohibited from bringing them to any sort of alternative to a hospital. Essentially, they're just having to take them directly to the emergency room. In many instances, if the person is in mild withdrawal or mild sobriety, they don't really need to be in a hospital setting. They really should be in a sober bed situation. All this bill does is essentially clean up the statute so that EMTs can essentially take a person to the mental health facility instead of an emergency room. I believe by the way, we've reached out to both opponents. I think there may just be a misunderstanding about who this is applicable to. This doesn't apply to locked facilities. This isn't applicable to involuntary admittance. This is solely voluntary if the person would prefer to go to a mental health crisis center versus an emergency room. And I'm happy to answer any questions.
All right, thank you. Representative Briel?
Just to clarify, the individual is given the option, or they know of the option, or how is the option conveyed, and who makes the determination if this is someone who could have either way?
Yeah. So in practice, EMTs assess the situation. They have the ability right now to request a waiver from DPH. That's generally what happens. It's a process where the EMT contacts the commander then contacts DPH. DPH will then say, okay, go here. This is just to sort of streamline that, so we're eliminating some of those. Every situation is not optional for a recovery center. Many situations, particularly if the person is in severe withdrawal, absolutely needs to be taken to the emergency room. So this is the type of situation where, frankly, there aren't many of these options. So it's going to be up to the EMTs to make those determinations. And again, these are centers that have direct relationships with a hospital. If a patient appears and it appears that it's not the appropriate method, they're going to be immediately transferred to a hospital. We think, frankly, those cases will be rare. This will keep people from having to go to emergency rooms when they don't need to be in an emergency room, and ensure that the people that do need to be in the emergency
admissions room are taken to the emergency room.
I really appreciate the thoughtfulness of this, and in a strapped environment, particularly rural areas. I think this is incredibly important. We have mental health crisis calls involving everything from drug use to schizophrenia regularly through our EMS, and I think this is great. So thanks.
Thank you. Are there any other questions? Minority spokesperson Hammond, do you have any questions? Great. There being no further debate, Representative Grassi moves that House Bill 5193 do pass. Is there leave? With leave being granted on a vote of 12 votes in favor and none opposed, House Bill 5193 is declared passed and will be favorably reported to the House floor. Y'all, we are so close. Good job, everybody. We now have House Bill 4785 with Chair LaPointe. I'm pulling it up. We need to, sorry, there it is.
It's all good. I can start if you're good with that, Chair.
Well, we need to adopt your amendment.
We do. That's right.
So, Rep. Ness moves that House Human Services Committee do adopt House Committee Amendment 1 to House Bill 4785. All those in favor say aye. Opposed say nay. In the opinion of the chair, the ayes have it, and the amendment is adopted. And I'm going to recognize Representative LaPointe after I say that there are 54 proponents. Just to give it a little flavor, we've got Heather Weyervott from Inseparable, Bianca Campos from Community Mental Health and Substance Use Providers, Bob Taylor from Trinity Services, and a lot of individuals. Do I have leave to waive the full list?
Yes.
Thank you. And we've got 4 opponents. Kate Morthland, Illinois Life and Health Insurance Council, Laura Menzer, Illinois Life and Health Insurance Council, Lori Reimers, and Jordan D. Ryan from the Illinois Chamber of Commerce. Oh, yeah, let me go back and check that one too. So that's, no, this is the, that it, I have the right witness slips. Thanks. That's okay. Take it away, Rep. LaPointe.
Thanks so much, Chair. I'll keep my comments brief so we can hear from Blanca and or Heather. So House Bill 4785 is a bill mental health advocates are behind this spring, and it's related to the bill that we just talked about. So, broadly speaking, this bill creates another mechanism to bring more financial resources into building out our three-prong crisis response system that all of us, our families and constituents, should be aware of and be able to use, but it's not funded and certainly not implemented at scale yet. That three-prong crisis system includes the 988 suicide prevention crisis lifeline that everybody knows about, that's in operation 24/7. Everyone should know about it, but they don't. The second prong is mobile crisis response, meaning somebody to come when people are in behavioral health crisis, no matter where you are in Illinois, and we need public awareness so everybody knows about this. And then finally, the third prong is a place to go that is not jail and not a hospital. Something that could look a lot like the Crisis Recovery Center in DuPage County that we just heard about. The place to go could be a living room, which is a model that DHS funds. It could be a crisis stabilization unit. It could be a crisis response center like in DuPage. The state has been slowly building out this system, funded by things like a 988 telecom fee, funded by Medicaid when the person is on Medicaid, funded by ARPA dollars. We've actually even used some cannabis funds to slowly build out this system. But commercial insurance is a payer that hasn't been paying into the system. So broadly speaking, this bill seeks to create a mechanism where commercial insurance would also be chipping in so we can continue to build out our three-prong crisis system. And I'll let the other witnesses share any more detail.
Representative LaPointe. My name is Blanca Campos. I am the CEO of the Community Behavioral Healthcare Association, and our members provide mental health and substance use services to individuals across the state of Illinois. That includes children, youth, adults, and families. But thank you so much for the opportunity to provide testimony on House Bill 4785, which requires commercial insurers to contribute to the statewide 988 fund through a modest $1.25 per covered life assessment. And as Representative shared, Representative LaPointe shared, since the launch of 988, the 24/7 suicide in crisis lifeline. Illinois has been building a crisis continuum designed to provide an alternative to emergency room and jails. This system is built around the three core pillars that Representative LaPointe mentioned: someone to call, someone to respond, and somewhere to go. And together, these components create a more effective, person-centered, and humane response to individuals in crisis. But building the system, as we all know, is not enough. We must be able to sustain it. Federal guidance and national best practices are clear. Crisis services require a multi-payer approach that includes commercial insurance. Today, Medicaid grants and the 988 fee are carrying most of that burden, but they were never designed to do it alone. 988 helps build that infrastructure. It does not replace insurance coverage for care. So without commercial participation, we create gaps in access. We shift costs to the state and taxpayers and push individuals into the most expensive settings. This bill really is about fairness. It's about sustainability. It ensures that all payers contribute their fair share. It strengthens the crisis system. It advances parity. It reduces reliance on high-cost hospital care when it's not necessary. If we treat a heart attack as an emergency that insurance must cover, we should treat a mental health crisis the same way. So importantly, this is not an added cost. It is a cost-saving strategy. Mobile crisis response works. Just last week, one of my members shared compelling data demonstrating its impact. So from February 2024 to February 2025, that agency conducted 142 in-person mobile crisis responses, with 95% of individuals stabilized safely in the community. From February 2025 to February 2026, that number more than doubled to 92 in-person responses, with 90% of individuals stabilized safely in the community, demonstrating both growing demand and continued effectiveness of mobile crisis response. And again, this is just one example, with approximately 68 agencies across the state providing mobile crisis response. It really translates into hundreds of crises being resolved without hospitalization or law enforcement involvement. As we all know how expensive hospital-based care can cost, $10,000, $25,000 more, depending on the episode. But by contrast, mobile crisis response delivers effective person-centered care at a fraction of that cost, meeting individuals where they are, often in some of the
I'm gonna cut it in here.
yes.
The sponsor has informed me that this bill is coming back.
Yes.
There's going to be an amendment. So let's go with the truncated version of
She gave the amazing truncated version, but any time, because as Representative LaPointe said, anytime we get an opportunity to share all the work that our state is doing to help people in behavioral health crisis, I really like taking advantage of it, but she really covered it when she started.
Great.
So
Thanks.
I'll cut my remarks short.
Thank you.
Thank you for your time.
Does the opposition want to share anything? Do you? And again, the opportunity, we're gonna take the deep dive when you come back. So
Yeah, no, absolutely. Laura Minzer with the Illinois Life and Health Insurance Council, thank you for the opportunity, and thank you to Representative LaPointe and the proponents for taking the time. We've met twice already, I believe, on this particular bill. We have expressed our concerns around some of the operational definitions, the mechanics of it, how it works, but I will be very transparent with all of you. Our overarching concern is the cost that this will apply to the fully insured market, specifically. Back of the napkin math would suggest where we would add an additional $30 to $35 million just to our individual small and large group products, which in this time when we talk about affordability, that is a challenge. So with that, I will bring my remarks to a close. We do look forward to further conversation as always, but wanted to make sure we were on the record that we might not solve all our issues. So thank you.
Appreciate that. Thank you. Are there questions from members? Leader Hammond.
And I will keep it short, understanding that this is coming back, and Chair LaPointe, I hope that you can get there and land this airplane in an appropriate way, but I'm hearing things like this is not an added cost. That to me sounds a lot like free money. And we know there is no such thing as free money. So there is going to be a cost, and I think that we, in good faith, need to acknowledge that there is going to be a cost. There's going to be a cost to the insurance companies. There's going to be a cost to families. There's going to be a cost to employers and small businesses, certainly. So let's just put that out there. because everybody wants to help with behavioral health. It's huge in all our communities. It's not indicative of a zip code. It's across the entire state and the entire country, and we want to do what we can, but we can't keep putting that burden on the taxpayers and just saying it's okay, it's free.
Could I respond to that briefly, if you don't mind? Yeah. Heather Wire, Vaught on behalf of Inseparable. Leader, you're absolutely correct. Someone has to pay for this. And the reality is right now, 80% of crisis services are entirely funded by the taxpayers. That, and by the way, it's really 100% because the 20% comes from the telecom fee. So everybody who uses their phone pays that fee that goes to crisis services. 100% ultimately is funded by the taxpayers. Commercial insurers are not required to provide coverage for crisis services. So any crisis services that they're with all due respect, their only contribution is any services that they're required to cover. Right now, out of network costs for outpatient mental health services are 3 times higher for commercial than the requirement to use out of network is 3 times higher for commercial payers. So in most respects, the person who has commercial insurance that has a crisis is paying out of pocket now. The insurance isn't covering it. And often, because they're paying out of pocket or they can't pay out of pocket, the taxpayers are then subsidizing it. So the intent of the bill is to take this portion, which, by the way, we're estimating $200 million is going to be necessary for us to meet our federal mandate by FY 29. We're asking the insurance company to pick up less than a quarter of that percentage. And so when we say the insurance industry would be picking it up, they're already required by law to have and provide some of these services. They're not mandated to provide crisis service. So essentially, instead of providing crisis services, they would be asked to pay $1.25 for each covered life.
And then,
if they were covering those crisis services, we wouldn't have this problem.
So real quickly, one follow-up is the assessment, after 2 years, the assessment would be set by the Department of Human Services. Are you looking at a ceiling on that?
Yes, that's one of the items that we're in conversations with the insurance industry about.
Thank you.
Are there any other questions? Right, seeing none, Rep. LaPointe, I just want to get your commitment to hold on second for an amendment.
Yes, we will be back in committee, and for the record, I echo everything Heather Weyerbach just said, that the cost to the system today is borne by taxpayers. It's borne by our emergency response systems as people cycle in and out of the crisis system. So there's a huge cost today, and that is what we're trying to reverse. And finally, when people are able to, when insurance companies do a much better job allowing people to use their commercial insurance for behavioral health, it actually drives down physical health care costs. So just wanted to say that for the record. Thank you, Chair.
Thank you. All right, there being no further debate, Rep. Grassi moves that House Bill 4785 do pass as amended. Is there leave?
Partisan pending the amendment, please.
With partisan leave pending an amendment, there are 8 votes in favor and 4 votes opposed. And House Bill 4785 as amended is declared passed and will be favorably reported to the House floor. LaPointe back in the chair.
Thank you so much. I think we're clocking in at 2 hours and 30 minutes. The House Human Services Committee will recess to the